Okay, we're good to go. Last session of the meeting, and I'd say a good marker of a good meeting is having actual people at the last session. So this is amazing. Great. So the purpose of this last session, you heard about clinical trials already, and so the purpose of this session is to kind of think about future clinical trials, considerations for clinical trial design for GBA Parkinson's disease. And so I'm pleased to welcome the first speaker, Dr. Peter Bauer from Centogene, who's going to talk about trial-ready populations.
Yeah, thank you for the invitation. Really great meeting and great to be with you and still see so many around. I'm disclaiming as well a couple of stuff. I'm a geneticist, so I'm not really the expert for trial-ready populations and what needs to be done to kind of keep them in a quality for anything that might pop up in the future. But when tasked to talk about that, I was happy that there's an end and the future of clinical genetic screening, which I happily take, and I added that I would like to share with you a little bit the ROPAT experience, which was kind of born out of the need that a trial-ready cohort was not available when Denali wanted to kind of prepare. And thanks the guys from Denali that always supported this collaboration. It was a great collaboration. So this is the cliffhanger, and I will just put it on the board that you can read. That's the question: what do we call a trial-ready cohort? What is the definitions, and what would you think should be in, and what might optional? What is mandatory? I think that's a very important debate for the people here in the room to work jointly on the potential together with the patients and the patient organizations, because it's much more than just doing genetic testing. But I will come to that in the end of the talk. 2018, when we started to talk with Denali, and they said, well, we want to kick off a clinical program. We need roughly 600 patients. They should be LRRK2 positive, of course, and the diagnosis should be close. So we want to have patients that are not advanced. It was very clear immediately that there was not a cohort around, that they could go, and there was no registry. Also, Christine Klein and movement disorder people already worked on a publication just putting everything that was published, which was a predictor that probably these hundreds of LRRK2 patients can be found. But there was no address and no kind of way to get them activated for a trial. So that was kind of a little bit disappointing, but turned around. We met, we engaged with the experts, neurologic experts, and discussed how can we start something that is not yet there. And so during the MDS conference in Hong Kong, we kind of framed out what is important for the stakeholders, that we get buy-in, that the sponsors as well happy with what will be achieved, but as well that we are decent in achievements. And what was very clear from the beginning is that if we start with genetic testing in a cohort to go for a marker, it wasn't enough just to do the LRRK2, although that was the primary focus. Consensus was there that if you take a blood sample from a patient and the only kind of return is a genetic information, it should be comprehensive. And so we designed that as well with the understanding that we should touch on Parkinson's disease. We should pretty open to include patients, all ages, just to give back something to the clinicians that was more valuable than just giving them some money for a clinical sample. So I think the fact that we as well tried to report in a clear way what is the result was very important in a good learning. So in the end, it was designed as an observational study, and overall in this first phase we sampled 12,000 patients with a clinical diagnosis, all adults, and we did that with dried blood spot filter cards, which is something I will touch later as well in the second part. And as said, it was more than just GBA and LRRK2 genotyping. We did a gene panel and reported on the by then known Parkinson genes to every individual that participated. That was the setup. This was the coverage, so we were in 3.5 continents, had at peak 120 sites. And we've seen that first and foremost we could deliver on identifying these patients, and the numbers were steady growing. And we got in return a clinical data set structured on dimensions of these patients as a snapshot shown on the right for the full cohort, with panel sequencing as the basis back in this phase. And we had as well consent to go beyond, which was then genome sequencing in 2,500 individuals, and as well with the filter card doing some biochemical data. We didn't know back then that we also can do transcriptomics, because that's something we learned in the last 4 years, but the card was there and the consent was there to do nucleic acid analysis, so that was great. Now, I just share a couple of results, but I don't want kind of really go through. There's nothing special about it. It's just needed to have a solid basis and say, if we do that, we know what we can expect, and there is some expectations, but the core is something we would predict, and we can as well thereby predict success in these patient-finding programs. And so there is male to female proportion like you would expect with Parkinson patients, structuredly to know what is the family histories in these Parkinson patients, but has not been as scaled in these countries before, and so we can return this fraction as well, break it down into countries and see a little bit what is differences. So 27% have indicated that there is another relative with Parkinson's disease. And then as well, this is an interaction with a sponsor. Of course, diversity is always guided if you want to run clinical programs, as well with the feasibility where you can do the programs, and therefore we are not as diverse as we would like to be and should be. But we started with good centers that have seen very many Europeans, but there is as well reported diverse ethnicities within the program. And you can see as well on the left side that age at onset, at diagnosis, and at enrollment is like you expect. Just to point out that this delay between the clinic diagnosis and the genetic test, 7 years, of course, is something that we have to show that we get closer to a diagnosis in the future. What we could do with the genome sequencing data is kind of qualify whether the self-reported ethnicity is something we see as well in the sequencing data, and there is big concordance, but as well sometimes you can say those that didn't know what is their ethnicity for any reason, we could at least help to see where they would fit best, and that's as well important if we go for burden for some pathways and genetic modifiers that sometimes has as well very diverse ethnicity allele frequencies. So this is kind of the main result to say, yeah, we identified more than 1,300 GBA1 PD individuals, so this is more than 10% in the cohort, and then it goes down with many LARC2 patients, 1% Parkin, and everything else is rare, but sometimes in the 20s and sometimes just casuistic cases. We have a couple of double positives, which is interesting, and so all overall close to 15% positivity rate. In GBA1 we reported as well the risk alleles that are not causing Gaucher disease, and so they make 50% of the observations we've done in this global cohort. Update, of course, now with the African variant, you heard it, we have to add another 64 individuals that have this type of Parkinson's, GBA Parkinson's disease, and since we have a diagnostic consent, they have received or will receive our notification as well, update reports, so that this become active and actionable. And next update, very recent, of course, there's as well RAP32 cases in this cohort, which we could not see in the whole cohort because RAP32 was not covered by the panel. But in the 2,500 genomes, of course, we checked, and you could probably expect that these numbers are 4 times higher if we would have done RAP32 genotyping in the whole cohort, maybe a max. So what we can say today, and I think that's as well important, this is a cohort we did an analysis 2 years ago, and today talking, I have to change the numbers because things are not stable. Neither the patients nor the genetic information is something you can really set in stone, and we have account for that in trial readiness as well. I will quickly go through that because it just, again, mirrors what you expect. So we have, of course, more males and females, but if we have a genetic diagnosis, all those that are autosomal causes level out a little bit this disparity, and we get more, relatively more females in the gene analysis positive cohort than in those that are without a genetic finding or relevant genetic finding. And of course, if you would ask for family history, that would guide you as well for a higher diagnostic yield, and you should always do that going forward. If you have a Parkinson's patient, ask whether relatives have Parkinson. That's a good predictor as well to focus your resources with genetic testing on those where you have a higher diagnostic yield. We can look at age at onset, and as well, no surprise, there is a 4-year difference between those that don't have a genetic report or a finding and those that have. So this is the accelerated progression, probably. And we can even look into the different genes as well, all published. GBA, LAG2 are maybe slightly earlier, while of course the recessive one have 15 to 20 years earlier onset, and synuclein is kind of in between. There is a few atypical diagnoses we've made, so because we had genes at kind of the phenotypic overlap into dystonias and dyskinesias, and you can see that there is 34 patients with dystonia, Parkinsonism, CH1, the most important genetic finding. We have a couple with epsilon sarcoglycan mutations, and we have as well 29 that showed Parkinson's symptoms early with clear dementia findings, or genes associated with dementia, granulin being the most prominent there. So just to summarize here the first part, that's kind of the headline as well in the paper that we will have in print in the summer together with the PD generation paper. And so I think it shows the relevance of genetic testing in the gene-targeted trial era. And I think that's my comment. Nothing is surprising here, but I think that's a good basis to say we are robust. We have tools that can show something at scale that you would expect from the literature. There's a couple of then, of course, numbers and findings that help us now to predict success if we continue these exercises. And one that I already mentioned is if there is a positive family finding, you can easily almost double the positivity rate of genetic screening. So from my perspective as a geneticist, that should be mandatory in kind of the clinical assessment of patients. There's a small number of patients that look like Parkinson patients, idiopathic, but they have kind of related disorders with dystonia and dyskinesia. And I think these results, we also, of course, since we returned to the results, have been great to inform patients how they can be active in the future. And that's the main part of genetic counseling post-test that I share with the patient, that knowing that, although the treatment is not yet around the corner, enables an active participation in what will happen next. And maybe one mention as well, this is now 6 years going on, and we haven't seen that we depleted the positivity rate over the 6 years in these centers, which means you will always see new patients with the very same or similar genetic findings, which is as well a good sign, so that the early effect of course, going into the pool of patients that lacked genetic testing later still will give you similar positivity rates. Now, before I go to the next part, 140 co-authors on that paper. It was really an ambition to collect all these signatures in the end. But even that's something we could do. Let's look beyond genetics, because I think when we discuss trial readiness, and we know there is a poor genotype-phenotype correlation, probably genotyping is essential but not enough. And here I think something kicked in that was not really foreseen, but we got as well some funding to do biochemical analysis. This was outside kind of the Denali interest, but there was a high scientific interest in that. And so we could do some lipid profiling in a cohort with almost 3,000 of these Parkinson patients and 3,000 controls. And I can just show you, for example, in blood, we discussed it this morning in brain, but in blood, the patient age and the GCase activity doesn't change. No? That's something that we didn't look at with the test before, because we developed GCase for Gaucher patients, and there is always almost zero, so I don't have to look whether the age is a factor that affects my test. But now offering this test for Parkinson patients, I have as well to work on the intended use and the validation of my test to make this something that I can offer for other patient populations. We do transcriptomics, and you've seen as well Christian's presentation on the African variant world, where this kind of missplicing and this small amount of transcripts are kind of the key finding of maybe what is early in as well involved in pathophysiology. But now I just want to take you a little bit deeper how we work then, and that is probably as well part of trial readiness, doing more than just the genotyping. So we have these filter cards, and this is for this ROPAD1 study, it's more than 12,000. We have as well the same filter cards from other programs, more than 100,000. And what we usually then do, next step is to go for the GBA positives, Parkinson positives. We identified GBA positive carriers, same age, that do not have Parkinson's, 800. And we had 2,500 that were either Parkinson positive but GBA negative, or the healthy age match that didn't have a genetic problem in GBA. And so this is a little flaw in the numbers. It was 840. I wanted to correct that. We had as well a couple of Gaucher patients just to show how this biochemistry works when it's really damaged. And GCase, for example, in the whole cohort is close to normal, 4.8. So in the healthy, you are a little bit above 5, and I will show you the breakdown between Parkinson and age-matched controls. Next slide, but in Gaucher patients, it's just 1/3, highly significant. The lyso-Gb1 is almost not elevated, and it's around 300 in these 130 Gaucher patients, and the same true for the glucosylceramides. So the test designed for Gaucher patients also applied now in Parkinson patients. What do we see? And we asked the question, is there something GBA Parkinson specific related to GBA carriers or Parkinson positives, or do we see as well abnormalities that characterize the disease state? For the direct the enzyme and the biomarker, we see that the status of GCase kind of decides what we see. So we see a slight decrease in GCase activity when you have a GBA1 variant, out of these that we called relevant for Parkinson's. And it doesn't count whether you have Parkinson's or not. If you have this variant, you will see the biochemical phenotype. Likewise, you see a slight elevation. This is maybe 20%. That goes up when you have a GBA variant, not accounting whether there's a phenotype or not. I think that's something we can accept. If we look into the ceramides, it looks different, because here we see that ceramides are always a little bit higher. Once again, 30% when you have Parkinson's, and they are not accounting for the GBA status. So this is type of, as well, not very new, but here we have large numbers, and we can, from these large numbers, say GBA plus Parkinson plus is nothing special, so it you can't kind of distinguish the phenotype with the genotype. If there's a variant, we see abnormalities in lyso-Gb1 and the GCase activity, while the glucosylceramides are associated with a clinical PD status and not with a genotype. And so just something that we don't know how to explain yet is that why is this higher than expected if you have a neurodegenerative disease, something we discussed the last 2 days as well, at least partly. But now with these numbers, I can go deeper. I can go for the 200 E365K, 200 T49M, 200 N49S, and of course the severe we had less, 80, while all the others usually are as well rather the severe one. And there we can check what happens now with GKs, and I think that's very nice data because we can show that the more severe we think this is, as well we see that GKs goes down to kind of a max of 30% in the severe variants that also cause severe Gaucher disease, while the mild ones are just 10% reduced. And likewise, lyso-Gb1 goes the same up, not to 30%, just 20%. But you see it's pretty nice correlated and helps us now to as well do this severity score, at least on the mutations. We can ask whether we see something in the ceramides. We don't see, so the genotypes don't kind of modify that. And Steph always said you have to go into details and not kind of the total. Here's the details. It looks a little bit more chaotic, but still I don't have the resources to extract any really biological story out of these markers. We collaborate now with the colleagues in Ottawa because I think they have the most elaborate bioinformatic tools to dig deeper. Age at onset, I think that's maybe a little bit surprising that at least in ROPAT, it looks like the risk alleles and the mild ones are pretty similar. The L444P is the more severe, and you see as well in the more severe, your variance is a little bit larger. So that makes more variability in the system, and if you plan to take these patients for a study, be aware that probably standardization of these patient cohorts will be more difficult as going for the milder variants. So just to summarize here, I think with the multi-omic ROPAT resource, I think we can, in this topic of trial readiness, go closer to an aim to be well-characterized or have well-characterized cohorts with hopefully standardized tests. And we have a couple of observations, of course, out of this multi-omic analysis we have already done that helps to inform clinical stratification. We see that we can as well have a genotype-specific GCase, and we can as well look in markers. Ceramides, still a little bit a riddle, but maybe something we will find very interesting in the near future when we have models to explain that. And these factors that drive this ceramide catabolism or anabolism still can be researched for. Bottom line, and I think that's the segue to the last part, what I think trial readiness could be. This is a tool to have comprehensive characterization that helps in patients and controls and can be or become a standardized tool to prepare for trial readiness. What we miss, and still of course everybody has on his list, is that we then transform this observational data into longitudinal data, which we also have to find solutions and create if these initiatives are already run. So what is called a trial-ready cohort? There is, of course, a lot of literature. I took a lazy approach and just wanted to have a summary. So I think this is cohorts that serve a clinical purpose, and they should be pre-screened and well-characterized, all good. I think a little bit flat, as always, with these language models. I think ROPAT only checks the pre-screened. We have some clinical information, but this is the biggest value. Everything else is not yet there, at least not systematically. Do we have something like that already in the PD field? Yes, there is SweetTrap, where this is tried with the REM sleep disorders. It started, so we don't have it yet, but it will come soon. But there's no genetics, and we learned, of course, yesterday with this screening parameter, you probably will not have any LAG2 patients because they just don't have this phenotype. So, two last pictures. Trial readiness leads to patients sitting in a waiting room because they start to engage somewhere, and then they start asking you, when can I participate somewhere in the clinical program? And you know how it feels to be a patient in a waiting room. We have as well to think about how we make that a comfortable feeling and not a frustrating and disappointing one. And I didn't mention that with this ROPAT publication, from 140 authors, unfortunately 3 already passed away in the last 3 years. From these patients that we have characterized, I could not even tell you, but it's of course more than 3. And trial readiness always means we have to always push something new in because it will be outdated or not available any longer, and we have as well to account for that with the efforts we take. Of course, we can't put the patients in the cooling room or in the freezer, but samples we can do. And I think, and that's my last slide, with my lessons, a statement, I think it could mean that trial readiness in the genetic era might mean we prepare for an ongoing, decent genetic screening approach at scale, ideally globally, to be diverse, and collect as well relevant biomaterials or non-biomaterial markers that help us to characterize this screening cohort, to enable us to fast forward into the deep qualification of a cohort when there's a specific call. And I finish with that. Thank you for your interest and patience, and maybe there's a couple of questions around these red highlight definitions. Thank you.
Okay.